Okay, I assume some folks will come straggling in, so we'll have a minute or two introduction. So I always am very fond of explaining to you, budding doctors, that when they've done surveys over what the most common topics of conversations are at cocktail parties are, of course, the weather, nowadays the economy, but always very high up on that list is, oh, I have high cholesterol, or my Uncle Bernie has high cholesterol, or my father has high cholesterol. And believe me, it doesn't matter what specialty of medicine you go into, your family and your friends are going to come to you and they're going to ask, well, what do I do? So hopefully after this lecture, you'll know exactly what high cholesterol means, why it's important, and importantly, also how to treat it. So a bit of a background. We have one of our favorite former presidents, President Clinton. And he was a bit of a lovable rogue, and one of the things that we recall about him is that, in fact, like many of us, he had some weaknesses. And those weaknesses were including the fact that he liked fast food. Now, we know that that's not good for us, and we know that sometimes very bad things can result. And unfortunately, this is what results from too much fat and cholesterol in the diet, and this is atherosclerosis. And what you see here is an artery, and we see a reorganizing clot there. And this white sort of cream cheesy stuff, and here we can see obviously an artery from somebody who's come to autopsy, is a real nasty inflammatory material. And this is where from a monocyte macrophage, a foam cell, we have an active plaque. And ultimately, that's so highly inflammatory, this can cause deterioration and ultimately rupture of the vessel wall. And when the blood contents come in contact with this incredibly gross inflammatory stuff, that's what sets up the inflammatory cascade, and ultimately we develop a thrombus, and that can be unstable angina, or in the case of this unfortunate individual, a total occlusion. You end up with a massive MI and end up dying. So that's the bad news. The good news is that we now know, after 20 years of clinical trial data, that not only is high cholesterol bad for you, but if you aggressively lower cholesterol, we can actually reverse this process. We can actually suck up all this lipid that's deposited in and behind the wall of the blood vessel, and we can actually stabilize the lining of the blood vessel so that it doesn't vasospasm, and we can actually get, if you will, a stable blood vessel for stable blood flow. So let's go back and discuss some of the basics of the physiology and the pathophysiology of lipids and lipoproteins. We'll talk about some of the genetic disorders so you can understand how that fits into the big picture, and also as a paradigm for overall sort of lifestyle-associated lipid disorders. And the most common lifestyle disorder associated with hyperlipidemia is the metabolic syndrome. And as you all probably know, a huge proportion of our society, unfortunately, currently suffers from the metabolic syndrome. Now, lipoprotein particles are spheroids, and they travel in the bloodstream. And they've evolved basically to transport hydrophobic substances, i.e. cholesterol and triglycerides, in an aqueous hydrophilic environment. And as a result, they're amphipathic. They can both exist in terms of having hydrophobic components and hydrophilic components. And on the surface of lipoproteins, we have amphipathic molecules, which include phospholipids, and also includes apolipoproteins. And again, they're the cargo container, if you will, for the contents, which are cholesterol, ester, and triglycerides. Now, this is one of my favorite slides. This is the so-called refrigeration test. And when you get on the wards, I bet you this is going to happen all the time. You're going to get a lab report back that says lipemic serum. And you're going to ask yourself, well, what does that mean? Well, that means if they have the blood tube out in the cold room overnight, if it's a normal blood tube, it's going to look like this on the left. It's sort of this golden clear color. But on the right, what we have is this sort of opalescent infranate with this sort of creamy stuff on top. That would be called lipemic serum. Now, I draw your attention to this sort of cream on top because when you put milk into your coffee, it has to be 1 to 2% before it actually turns white to actually make your coffee white. Well, in fact, these cream on top represents chylomicrons, And that's at least 1 to 2%. That's 1,000 to 2,000 milligrams per deciliter hypertriglyceridemia. So you've done this refrigeration test, and you know for sure this person has chylomicronemia, and they have triglycerides that are at least 1,000 milligrams per deciliter. So isn't that pretty cool? You made the diagnosis right there. So let's just look at a case real quickly, and we'll actually come back to this gentleman, Paul. So he's a 50-year-old gentleman. Like a lot of us, he has a sedentary lifestyle. He's been gaining weight. He's coming in for a health screening. And his physical exam is pretty benign, but he's got borderline hypertension. He's clearly overweight. And BMI is about 27. He's got a bit of the spare tire. His waist is 42 inches. You notice he's got some corneal arcus, but no xanthelasma or xanthomata. But otherwise, it's a pretty benign, pretty unremarkable exam. But then you look at his lab tests, and, well, they're not so normal. His total cholesterol is 252. His triglycerides are 210. He's got low HDL 35. He's got LDL that's elevated at 175. His glucose is sort of borderline. His fasting is 110. Hemoglobin A1C 6.2%. You sort of look at him and you say, well, what is this guy's cardiac risk factors? Well, he's over 45. He's a male. He's got low HDL. He's got essentially borderline hypertension. Turns out that he's got a family history of coronary disease. His father had a CABG at age 50. And interestingly enough, one of his brothers actually had high cholesterol. So this is clearly somebody who you're looking at and say, this is a higher than average risk, this individual. But what does he have, and how do we treat him? So think about that for a bit, and after we go over some of the basic pathophysiology, we'll come back and we'll answer those questions. So, okay, well, the questions will be, so keep these in mind. What lipid and metabolic abnormalities are important in the patient I just showed you? Does he have a genetic dyslipidemia? I'm sort of betting he does. Is he at increased risk of coronary disease? Quite probably. Are there any secondary lifestyle and environmental factors that might be important? I think definitely true. What should your goals of therapy be? Well, you definitely want to think about that. Is drug therapy indicated as compared to just lifestyle? And if we do use drugs, what drugs should we use and why? So these are all questions that we'll answer at the end of the talk. So let's go back and talk about normal lipoprotein physiology and pathways. And I like to think of all metabolites, but including cholesterol and triglycerides, are in flux. They're in motion. So the exogenous pathway is otherwise known as the chylomicron pathway, and it's the way we assimilate fat and cholesterol in the diet, and we actually package it up and make it available to our tissues. So we're eating fat and cholesterol in terms of the food. That fat becomes dissolved and assimilated, and then ultimately it gets packaged up as chylomicrons, which are secreted into the venous system. And chylomicrons are overwhelmingly majority triglycerides, 90% plus in terms of triglycerides, a little bit of cholesterol ester. On their surface, they have apolipoproteins, particularly ApoB48 and ApoE. And then that chylomicron particle is acted upon by lipoprotein lipase. And remember that LPL has an essential cofactor, apolipoprotein C2, which is an activator. And when LPL is activated, it basically cleaves off fatty acids from the triglycerides. It undergoes lipolysis. Those fatty acids will be taken up and stored, particularly in adipose tissue. And then you end up with a remnant particle that's about half and half triglycerides and cholesterol, actually a little bit more triglycerides and cholesterol. Still has B48 and ApoE on its surface. And then that particle is going to be taken up by a remnant receptor in the liver. So this is the lifestyle of how you have your chylomicron in the exogenous lipid pathway. Now there's another pathway called the endogenous pathway, and synonymous with that is the VLDL metabolic pathway. And this is the way we've evolved to deliver cholesterol, but particularly fat, during the fast. And this is a way of delivering energy, if you will, to energy-requiring organs, particularly muscle. So what the liver is doing as a synthetic organ, it's packaging up triglycerides and some cholesterol into a VLDL particle. Still predominantly triglycerides, but now it's about 5-part triglycerides to 1-part cholesterol. And we have, instead of B48, we have B100 on the surface. We also have ApoE. And this is secreted into the venous system. And just like chylomicrons, LPL can act upon VLDL. Still need ApoC2 as an essential cofactor. And after lipolysis, we develop a remnant particle, which is sometimes called a VLDL remnant, or synonymous with that would be an IDL, intermediate density lipoprotein, again, about half and half, triglycerides and cholesterol, a little bit more triglyceride than cholesterol, still has B100 and ApoE on its surface. And then this remnant particle actually has two fates. It can be converted further to an LDL particle, in which case we've lost the ApoE and there's just ApoB100 on the surface. Or the remnant particle can go back to the liver, where it can be taken up by the IDL remnant receptor, which interestingly enough is the same receptor as for the LDL, and we'll get back to that later. Now, one other point I want to make about the VLDL metabolic pathway is you'll notice that VLDL, the remnant VLDL IDL particle, and the LDL all have ApoB100 on their surface. And when we get to the latter part of this talk, that fact will become important. So again, just to recap what I just told you, the liver is producing VLDL. We get a VLDL or an IDL remnant. That can be converted to LDL, which can be taken up by the LDL receptor in the liver, or it can be taken up by LDL receptors in the periphery, or the remnant particle itself can be directly taken up by the receptor in the liver, and that receptor is the same one as the LDL receptor. So let's talk about the genetic dyslipidemias you're going to see on the wards. So the most common, and perhaps the best known, and the most important, I would argue, and I'll give you both a common name and also a sort of functional name for every single genetic disorder that you have, so that it's easier to remember and understand in your head. So the most common one is familial combined hyperlipidemia. Another name for that is hyper-ApoB. And in this case, the defect is that you have an overproduction of VLDL particles containing ApoB100. So we have too many of these. Now, of course, these are going to be metabolized in the pathway. So they're going to be metabolized down to the remnant IDL, and those in turn will be metabolized down to LDL. And the net result is there's an overproduction of VLDL, and in the bloodstream there's going to be an increased prevalence, increased concentration of ApoB100, representing a collection of LDL, IDL, and VLDL. Now, an important point to be made about familial combined hyperlipidemia, now we call it familial combined because on average most people will have a collection of these particles, so they'll have a high triglycerides, they'll have a high cholesterol, they'll have remnants, sort of a mixture of these particles. They'll have both high cholesterol and high triglycerides. They will have a combined or a mixed hyperlipidemia. But let's suppose that somebody's been overeating and they didn't fast very long. Well, the predominant particle in the circulation is going to be VLDL. So they're going to have a predominant hypertriglyceridemia. In contrast, if this is somebody who's very slim and very athletic and they're not overeating and perhaps they fasted for a good long time before you drew their blood, well, most of these particles will have been metabolized down to the LDL side of the equation here, and therefore they'll present as predominantly hypercholesterolemia. So this is a very important point about familial combined, the fact that you can present with different phenotypes. It can be combined hyperlipidemia, predominantly hypertriglyceridemia, or hypercholesterolemia. So that's a very important point. So it's the most common, as I mentioned. It's about 1 in 100. It's autosomal dominant in terms of its inheritance. And what's very important, and I just told you this, there's a variable lipoprotein pattern in the individual and also in family members. But that pattern can change over time. It very much depends upon the nutritional, if you will, situation of that individual. How obese are they? How much did they overeat? How long did they fast? How athletic they are? So it can not only change between one family member and another in any given individual, it can change over time depending upon the metabolic situation at that point in time. So again, multiple phenotypes combined, hypertriglyceridemia or hypercholesterolemia. Again, the important point is the pathophysiology is an overproduction of ApoB100 containing particles, i.e. VLDL, that can be metabolized downstream to remnants and IDL. And for our purposes, the reason we pay attention to this hyperlipidemia is because CHD risk is clearly increased. So here's one way to look at this visually. We have an excessive number of VLDL. We end up with an excessive number of the IDL and ultimately an excessive number of LDL particles. Too many ApoB-containing particles. And the reason I'm showing you this is to compare and contrast it, and this is also in your syllabus, is with another familial hyperlipidemia, and this is called familial hypertriglyceridemia. Now, I have to admit this is a somewhat poorly defined nosological entity. Also fairly common, about at 1 in 100, also has autosomal dominant. But the key factor here is you always have hypertriglyceridemia. And triglycerides will be anywhere between 200 and 500, so a moderately increase in hypertriglyceridemia. Not infrequently be associated with low HDL, may be associated with obesity and diabetes and hyperuricemia. But importantly, the CHD risk is not consistently elevated. If it's elevated, probably they have diabetes. And the important point is they have high triglycerides, but they do not have an increased number of particles. They do not have an increase in ApoB. They just produce a normal amount of VLDL, but they're very chock-a-block full of triglycerides, so they have hypertriglyceridemia. So this is what distinguishes it from familial combined. And again, the CHD risk is not consistently elevated, whereas with familial combined, it most certainly is. So again, here you have a normal number of VLDL particles, very enriched with triglycerides, sort of normal number of remnants and LDL particles. In contrast to here, where you have many more particles. Okay, got that? So let's move on to the familial hypertriglyceridemia, sort of in an extreme manner. And these have a variety of names, sometimes called in the Friedrichsen classification type 1 hyperlipoproteinemia. I again prefer the functional name, which is familial hyperlipoproteinemia, or even better, is familial chylomicronemia, because that describes exactly what it is. It's familial, and you have chylomicronemia. And in this case, you have a defect or a mutation in lipoprotein lipase or in ApoC2. So what's the net result? You can't lipolyze triglyceride-rich particles, and the particle that contains most of the triglycerides are your chylomicrons. So what's going to accumulate? You're going to accumulate chylomicrons. Now, inasmuch as VLDL also are acted upon by LPL, if that's defective, you may also, to a degree, accumulate those. But the bottom line is you're accumulating these triglyceride-rich lipoproteins, and in terms of chylomicrons, that means you can have triglycerides in the thousands. Now, fortunately, this is relatively rare. It's about 1 in a million, and consistent with it being rare, it's autosomal recessive in terms of its genetics. Triglycerides, even fasting, are typically over 1,000 on a normal diet. It presents in childhood, especially in puberty of girls. Anybody give me a thought over why that might present in puberty in girls? Any ideas? Increased body fat is mentioned. That's not a wrong answer, but that's actually not the main reason. The main reason actually is what happens in puberty. Your estrogen turns on. And estrogen is actually an important metabolic factor that drives the production of triglycerides. So that's why that would happen. Now, the pathophysiology, again, is a defect or a mutation. You could even have an antibody against the lipoprotein lipase or ApoC2, which, again, is the essential activator, cofactor for LPL. And the reason we're concerned about it is not just the very high level of triglycerides, but the end morbid results of having severe hypertriglyceridemia. And that would be, this doesn't cause problems, but on your body surface you can have xanthomatosis. But much more significantly, you can develop pancreatitis, which is not only painful, but potentially a life-threatening complication. You can also get hepatosplenomegaly. So here we have a picture of what's called eruptive xanthomatosis. This is when you have very significant chylomicronemia, triglycerides, 5,000, 10,000, very, very elevated. And typically, they'll show up, within an hour or two after eating a fat-rich meal. They look like mosquito bites. They're sort of this orangey yellow. They're sort of umbilicated, and they're highly pruritic. They'll end up being where the blood flow is a little bit slower, the skin surface is a little cooler, so it's going to be on the extensor surfaces like the knees, the elbows, also on the flanks and on the buttocks. And this is what they look like. And they'll stick around for a day or two, and then they'll slowly fade away. But this is basically deposition of chylomicrons in the reticuloendothelial system. Now let's just review for a moment sort of the VLDL, the remnant, and the LDL pathway, and for that matter also, I guess, chylomicrons. So remember, chylomicrons and VLDL are carrying your triglycerides. They have ApoB and ApoE on their surface. They're acted upon by LPL. You form a remnant particle. In terms of chylomicron, it would be called the chylomicron remnant. In terms of VLDL, it would be called the VLDL remnant or IDL. They have B and E on their surface. And those remnant particles can be taken up by the liver by the remnant receptors. In terms of the VLDL remnant, that also can be converted to LDL. So just keep that in mind as we go to the next genetic dyslipidemia. So the next one is called type 3 in terms of the Friedrichsen classification. Again, the functional name, which I prefer, is called remnant removal disease. Well, the name actually describes what the problem here is. So recall that the remnant particles not only have ApoB on their surface, chylomicron would be B48, VLDL it would be B100, but they also have ApoE. And ApoE has 3 isoforms, ApoE2 or E3 or E4. Interestingly, E4 is associated with increased risk of Alzheimer's disease. But if you're unlucky enough to be E2 homozygous, the combination of E2 and ApoB means that you actually have a decreased affinity for the remnant receptors in the liver. And the remnant receptors are very, very avid, very high affinity for the combination of ApoB and ApoE on these remnant particles, which is why remnant particles are in much lower concentration than, for instance, LDL in the circulation. But when you're E2 homozygous combined with ApoB, now all of a sudden you're low affinity for the clearance by the remnant receptors, so those remnants start accumulating, and that would be both the chylomicron and the VLDL remnants. So there's a number of synonyms for this disease in addition to type 3. You may also hear familial beta lipoproteinemia or broad beta disease. That comes from lipoprotein electrophoresis, where typically the VLDL and the IDL particles are very discrete band, but when you have a lot of them, you sort of get the schmear, the schmutz, so you get a very widened band, which is why it's called broad beta disease. Now, what's interesting, the clinical presentation of remnant removal disease is relatively uncommon, about 1 in 1,000 to 1 in 500. But a necessary but not sufficient requirement is that you must be E2 homozygous. That's relatively common. That's 1 in 100. And the reason the clinical expression is more rare is that you need a second hit. So that's necessary but not sufficient to be E2 homozygous. So what are some other second hits? Well, you could be obese or have out-of-control diabetes. You could be someone who's overeating and drinking a lot of alcohol. You could be a woman who all of a sudden is being put on birth control, so she has more estrogen. These are all things that are stressing the system, and you can't clear the triglyceride, the remnant particles from the circulation. So again, the pathophysiology of an impaired clearance of ApoBE remnant particles by the remnant receptors, and as a result, the chylomicron and the VLDL remnants accumulate. Now, how do you make a diagnosis? Well, first of all, you're going to have a combined hyperlipidemia because you have an accumulation of remnant particles. And again, the remnants have somewhat more triglyceride than cholesterol, but they're about half and half. Now, if we just were fasting and you just had VLDL in your circulation, well, let me rephrase that. If you measured the VLDL cholesterol associated with VLDL and divided that by your total triglycerides, which is coming from your VLDL, the ratio should be about 1 in 5, in other words, 0.2. Now, if the ratio is above 0.3, that implies you have floating in the same range as the VLDL particles that are otherwise cholesterol enriched, i.e. remnant particles. So when that ratio is above 0.3, that means you have a lot of remnants there. If you did a lipoprotein electrophoresis, there would be this broad beta band. Now, this disease is also important because not only can you have high cholesterol and triglycerides, but you have an increased risk for coronary disease, and interestingly, also particularly peripheral vascular disease. Now, in terms of the physical findings, what you may see, although not all the time, is palmar and tubo-eruptive xanthomata. Now, let me show you what those look like. So here we see stria palmaris, and this is in the creases of the hand. You're going to see this sort of orangey yellow and then a little bit on the creases of the fingers. And that actually is pathognomonic for remnant removal disease. So if you ever do see this, and I can tell you an entire career as a lipidologist, I've seen this twice. So you're probably not going to see it. But if you look at the hands, if you do see it, you've made the diagnosis. So it's pathognomonic but rare. If you have very significantly elevated cholesterol and triglycerides, cholesterol 600, 700, triglycerides maybe 8, 9, maybe 1,000, you may end up with these tuberous xanthomata, particularly on the extensor surfaces, particularly the elbows and the knees. And while these aren't pathognomonic for remnant removal disease, these are very suggestive. But again, this would imply a very, very severe and significant hypercholesterolemia, probably over a number of years. And you'll notice that this person also has eruptive xanthomata. So they also have chylomicrons in their circulation. They've way overstressed their system. Now the most, yes? Okay, so the question is, if you remove the second hits from somebody who has remnant removal disease, are you going to improve or totally reverse the clinical expression of the very severe hyperlipidemia? And the answer to that mostly is yes. So if somebody has out-of-control diabetes, they're obese, they're alcoholic, they're drinking, if you get that out of the way, you'll have a very substantial reduction in their hyperlipidemia. Now, they may still have a mild combined hyperlipidemia at baseline if they're doing everything right, but the severe expression of that will get dramatically better. So yes, great question. Any other questions? And by the way, feel free to interrupt me at any point. Yes, in the back. How is it different? In this case, you don't have hyper-ApoB. You just have a normal amount of VLDL and IDL, but what you're accumulating are the remnant particles. So ApoB in this case would be average. Does that make sense? Okay, but there's a lot of triglyceride and a lot of cholesterol that's incorporated in these remnant particles. So not a lot of them can very substantially contribute to the elevations in cholesterol and triglycerides. Any other questions? No? Okay. So the most famous genetic dyslipidemia is the one for which Goldstein and Brown got the Nobel Prize, and this is called familial hypercholesterolemia. In this case, the name describes exactly what it is. It's familial, and you have very significant hypercholesterolemia. So remember, we're secreting VLDL, we're making the IDL remnant particle, and that remnant particle gets converted to the LDL particle, and then that particle is going to be taken up by the LDL receptor. Now, if you have a mutation in the LDL receptor, what can't you do? You can't clear LDL effectively. So the net result is a very substantial elevation in your LDL cholesterol. So not surprisingly, because a heterozygous affected individual will have very elevated cholesterol, it's autosomal dominant in terms of its inheritance. The heterozygous condition is about 1 in 500 in the population. You can see individuals with homozygous FH, which is really severe, but that's fortunately rare, about 1 in a million. So how much is the cholesterol elevated? Well, to put it into context for you, an average level of LDL cholesterol in the population is about 125, maybe 130 milligrams per deciliter. Well, if you knock out one allele of the LDL receptor, you've reduced your clearance by about 50%, and therefore you approximately double your LDL concentration. So to make the diagnosis of heterozygous FH, you really have to have an LDL concentration that's above 250 milligrams per deciliter. Now, as I mentioned, you can have homozygous FH. You can knock out both alleles. It can be sort of a partial knockout, what we sometimes call leaky mutations. So, you can get 4, 6-fold, sometimes even more than that, elevations in LDL cholesterol, just really extraordinarily high levels of LDL cholesterol. So again, to make the diagnosis and in terms of the manifestations, you have to have an LDL above 250. And the reason we're very concerned about it is because there's a very substantial increased risk of premature vascular disease. So we see premature heart disease in affected family members, as well as the individual. And there's a lot of physical manifestations of high cholesterol, particularly over years and decades. So one can see what's called xanthelasma and corneal arcus, and I'll show you pictures of this, particularly in individuals even as young adults. We can get tendon xanthomas, particularly in the Achilles tendon. Interestingly, when you have very severe hypercholesterolemia in someone with FH who's younger, they may get arthritic joint pains. This is sometimes misdiagnosed as juvenile rheumatoid arthritis. You can treat that arthritis till the cows come home and nothing is going to help. But if you did effectively lower their cholesterol, those pains would miraculously go away. So it's sort of a nice little pearl to remember when you do your room rotation. And again, importantly, there's a very strong family history of premature coronary disease. So this is what corneal arcus looks like. It's this cholesterol that's deposited on the outer cornea of the eye. Now this is obviously a very common physical finding as we get older. So if you see this in someone who's 70 or 80, it's no big deal. It's a normal part of aging, and it sort of shows you that sort of cholesterol deposition and sort of damage to tissue and organs is a natural part of aging. On the other hand, if you see this in someone who's 20 or 30, this is grossly abnormal. You shouldn't be seeing this. This is evidence of cholesterol deposition in the cornea of the eye. And this is what xanthelasma looks like. This is cholesterol deposited in the inner canthus of the eye. And I would say about 95–98% of the time, this is due to hypercholesterolemia. There's a few rare dermatologic conditions that can sort of mimic this. And I always like to, tell this lecture that invariably this happens to me at least once per year. I'm in the, the checkout line in the grocery store, and, the guy in front of me turns around, and I'm staring at this. And then I look a little more closely, and I'm staring at that. And so what's going through my head? Oh, my God, this guy's got really high cholesterol. Well, do I say anything? And I sort of struggle with myself, and usually I sort of say, well, and by the way, sir, have you had your cholesterol checked? I'm always afraid they're going to take, great offense. And hopefully they have, but if they haven't, you can say, well, I'm sort of a endocrinologist, or I'm a cholesterol specialist, and, I suspect that you might have high cholesterol. You might want to get it checked. Hopefully they don't also have some cigarettes in their pocket as well. But anyway, you've just made the diagnosis of somebody with very significant hypercholesterolemia, and all you did was sort of look at them in the face. Now this is what Achilles tendon xanthoma look like if you have familial hypercholesterolemia. This is actually a young lady with homozygous FH, and where you sort of have this bulbous xanthoma. Much more typically what you see is thickening of the Achilles tendons. Now you don't always see this with familial hypercholesterolemia. In fact, it's in a minority of patients. But if you do see this, and this person has an LDL cholesterol of 250, and they have some family history of premature coronary disease, that's FH until otherwise disproven. This is essentially pathognomonic of the disease. Now, perhaps you have a patient who's a little overweight, maybe they have diabetes, and you're not sure if they have a thickened Achilles xanthoma. Well, one way to figure that out is assuming that you yourself do not have FH. Use your own Achilles tendon as a negative control. You say, okay, that's what normal feels like. That's what their Achilles feels like. Yeah, I think it's thickened. So you could say, okay, thickened Achilles tendon. Now, if it's not thickened, it doesn't rule out the disease. But if they do have it, that's a very important physical finding. Okay? Now, as you can imagine, these genetic disorders represent a minority of patients who have hyperlipidemia, although they are tremendously overrepresented in patients who present with coronary disease, which is why we're focusing on them. But the average person with high cholesterol will just have primary or so-called polygenic hypercholesterolemia. This is typically defined as an LDL cholesterol over 160, and that's a quarter of the population or more. And contrast that with familial combined, that's about 1 in 100, or FH, which is 1 in 500. Now, how about diet? Diet certainly is important. It can exacerbate existing hyperlipidemia, and it does this in a number of interesting ways. First of all, if you're overweight and you're overeating, you're overproducing VLDL particles, so that's going to contribute to hypertriglyceridemia. Inasmuch as those particles will get metabolized to LDL, that can contribute to hypercholesterolemia. And if you're on a diet that's very enriched in saturated fat and cholesterol, but particularly and more importantly, interestingly, is saturated fat, that has the effect of reducing the activity of the LDL and the remnant receptor here. So the net result is that LDL particles are cleared more slowly. So this is also going to contribute to hypercholesterolemia. And inasmuch as you have some remnant particles, around, that's going to contribute to a combined hyperlipidemia. So that's how diet works, and obviously the reverse is also true. If you improve your diet, that's going to improve your dyslipidemia. Now here I just list sort of acquired and sort of environmental factors that can exacerbate pre-existing hyperlipidemia, and those that are predominantly associated with hypertriglyceridemia on the left, and particularly diabetes, obesity, and alcohol, and estrogen. And those particularly associated with hypercholesterolemia, and that would be particularly hypothyroidism would be an important one to know. So those are all things that can contribute to dyslipidemia, so when you're evaluating the patient, you want to think about those. Just a brief word about HDL. We used to think we understood HDL really well. Now I think we're not quite so sure. One thing that we still definitely do know about HDL, it is a very potent and significant predictor of heart disease at baseline. So in other words, if you have low HDL, that's a very strong predictor of heart disease. And if you have high HDL, that's actually predictive or anti-predictive factor for future heart disease. Now, what do you do when you're manipulating HDL? That's a issue that has become highly controversial. So we really don't have an answer for that. But in terms of HDL, in terms of baseline, it's still considered a very important risk factor. So what is HDL? HDL is essential in the so-called reverse cholesterol transport. And there is a direct and also an indirect pathway. In terms of the direct pathway, most organs of the body, including monocyte macrophages, make a slight excess of cholesterol, and that cholesterol has to be returned to the liver. So the cholesterol is exported first by the ABC1 transporter into the nascent HDL particle. That free cholesterol is then acylated. A fatty acid chain is added by an enzyme called lecithin cholesterol acyltransferase. You then get this mature, buoyant, sort of juicy HDL particle that's a very potent antioxidant particle. And that can be taken up directly by the SRB1 receptor. So this is the direct reverse cholesterol transport pathway. Now there's another pathway called the indirect pathway, which interestingly enough is more important. And by the time we get to the mature HDL particle here, we can actually transfer or exchange cholesterol out of the HDL particle into the VLDL particle. And that's done by an enzyme called CETP, or cholesterol ester transport protein. So you're transferring cholesterol out of the HDL into the VLDL. And then that VLDL, of course, will be converted ultimately to an LDL, which will be taken up by the LDL receptor. So this is the indirect reverse cholesterol transport pathway. And in fact, that accounts for the majority of cholesterol transported from the periphery back to the liver, interestingly enough. Okay. Now, I'm not going to go over the genetic causes of low HDL because they're quite rare. They're in your syllabus. But I do want you to pay attention to the fact that there are important secondary and very common causes of low HDL cholesterol. And those would include things like smoking, if you're obese or have visceral fat, you have a sedentary lifestyle, you're on a high carbohydrate or very low fat diet. And the most important secondary cause is hypertriglyceridemia from any cause, and also a number of drugs as well, beta blockers, androgenic steroids, or androgenic progestogens. And the reason it's important to focus on these secondary causes of low HDL, by definition, they are reversible. So when we talk about lifestyle or other interventions for our patients to raise HDL, this is something that is eminently doable. Now it's time to sort of transition over and say, well, what's the relationship between HDL and LDL and the metabolic syndrome, and why do people with the metabolic syndrome have disproportionately increased risk for atherosclerosis? Okay, it turns out that there's some very important links between cholesterol, triglyceride, HDL, LDL, and the metabolic syndrome. So the first thing to realize is, and this is what's going to be emphasized more in the future teachings from the atherosclerosis treatment panel, that'll be coming out probably in the next year or two. But the fact is that LDL is not the only atherogenic particle. It's certainly the most common and the most important atherogenic particle. But actually the precursor particles, the IDL and small VLDL, can also contribute to atherosclerosis. And all of these particles, I should point out, have ApoB 100 on their surface. All of these particles do carry cholesterol, albeit LDL is the most predominant particle and has the most amount of cholesterol. So when we think about total atherogenic cholesterol, it's the cholesterol associated with the VLDL, with the remnant IDL, and also with the LDL. And this is nothing other than your total cholesterol minus your HDL cholesterol. So this has been given the term non-HDL cholesterol. So when somebody says you have high non-HDL cholesterol, what they're really saying is your total atherogenic cholesterol is high if you have high non-HDL cholesterol. Now, I mentioned that the most, I didn't mention, I will mention now that the most important finding in terms of the lipid profile is whether there's hypertriglyceridemia. Because hypertriglyceridemia is a very important marker for the metabolic syndrome and for atherogenic dyslipidemia. So first of all, it implies you have an excessive amount of triglyceride-rich lipoproteins, particularly the remnants that are coming from chylomicrons and the VLDL. In addition, it's invariably associated with low HDL cholesterol. And remember, low HDL cholesterol predicts increased atherogenic risk. But it also, and this is an absolutely key concept, is associated with an increased amount of small, dense LDL. Okay? Whenever you see hypertriglyceridemia, 95% of the time associated with small, dense LDL. So first let me explain how it occurs, and then I'm going to explain why it's so important. Now, the metabolic syndrome, you may have heard, is sometimes also called the insulin resistance syndrome. And insulin we tend to think of in terms of diabetes and glucose and sort of resistance to reducing blood sugar. But there's actually another pathway, the fat pathway, that's also sensitive to insulin. And what happens is that fat cells can undergo lipolysis, and there's the release by hormone-sensitive lipase of fatty acids. That's actually an insulin-sensitive enzyme. And you can be insulin resistant in terms of lipolysis. So as a result, you can have an excessive and inappropriate release of fatty acids, and those fatty acids will be cleared by the liver. They'll be re-esterified into triglycerides. It'll promote the synthesis of ApoB-100. That will be packaged into VLDL particles. So now we have an excessive amount of VLDL particles, and our old friend CETP, cholesterol ester transfer protein, says, okay, we have a lot of triglycerides here in terms of a lot of particles. Why don't we go ahead and start exchanging that cholesterol? Let me rephrase that. The cholesterol ester transfer protein said, let's exchange cholesterol where it's in excess, which would be LDL and also HDL. But we can't exchange it in a vacuum. We have to exchange it for something, and that something is triglycerides. So cholesterol is moving out of LDL into VLDL in exchange for triglycerides, and out of LDL into VLDL in exchange for triglycerides. So now we have HDL and LDL particles that are triglyceride enriched and cholesterol poor. Being triglyceride rich, they're prone to oxidative modification. So now we can have an oxidized LDL and an oxidized HDL. And also being triglyceride rich, they're now substrates for lipases like lipoprotein lipase and particularly hepatic lipase. So now they can be chewed up and they become smaller. So now we have, particularly in terms of LDL, but also HDL, we now have an oxidized, small, and dense LDL particle. Well, why is that important? It's important because now we have a particle that's depleted of cholesterol. And the other way to think about that is for any calculated level of LDL cholesterol, you actually have an increased particle number. And it turns out it's actually particles that cause atherosclerosis, not some static level of LDL cholesterol. In addition, as I mentioned, they're more prone to oxidative modification. They can be taken up more avidly by the scavenger receptor. There's greater arterial uptake and greater uptake by monocyte macrophages. So this is promoting atherosclerosis. So small dense LDL, there's more particles for any calculated LDL concentration, and pound for pound, mole for mole, they're worse particles for you because they're more oxidatively modified and they're smaller. Same can be said for HDL, but now we have an HDL particle that's cholesterol depleted. It's oxidized, so it's not working as well as an antioxidant molecule. It's not being as effective in preventing atherosclerosis. So again, this is invariably associated with higher levels of triglyceride. LDL may or may not, cholesterol, be elevated, and we'll have decreased concentrations of the large, buoyant, particularly HDL cholesterol. Now, this is something you absolutely positively have to know, okay? And not only do you have to know it for this course, but you're going to have to know it when you go onto the wards. I guarantee you, as medical students, as residents, when you move on your medical career, someone is going to ask you, how do you calculate LDL cholesterol? So you're going to have to memorize this. You might as well start now. So what's the Friedewald equation? The Friedewald equation says the LDL cholesterol is your total cholesterol minus your HDL cholesterol minus your triglycerides divided by 5. Why triglyceride divided by 5? Well, remember our old friend VLDL. It's 5 parts triglyceride, 1 part cholesterol. So we're taking that part away, we're taking the HDL away, and what's left over is your LDL. Now, it turns out that the Friedewald equation starts to break down when your triglycerides get too elevated. Above 400, it's a totally invalid equation. In fact, it already starts to break down when triglycerides are getting above, about 200 or so. So it's already underestimating your total atherogenic LDL cholesterol risk, which is why it's been proposed that you should think about and evaluate non-HDL cholesterol concentrations whenever triglycerides become over 200. In other words, your total cholesterol minus your HDL cholesterol. So again, your total risk is the total atherogenic particle number, not the static level of LDL cholesterol. So here we have 2 patients, one with large, buoyant, juicy LDL of 125. This guy also has an LDL cholesterol of 125, but has twice as many particles. Not only are there twice as many particles, but they're also oxidized. They're smaller, they can infiltrate. They get taken up by the scavenger receptor. So this person has a much greater atherogenic risk as compared to this person, and yet they have equivalent levels of LDL cholesterol. So what kind of targets should we be defining in terms of getting our cholesterol levels down? Well, if you're at high risk, which we generally define as somebody with pre-existing heart disease or peripheral vascular disease, or for that matter, type 2 diabetes, the goal is clearly an LDL less than 100 milligrams per deciliter. In fact, the guidelines suggest everybody should get their LDL cholesterol below 100, but depending on whether you want to use drugs or not, you may be happy between 100 and 130 if you can just use diet. But if you're high risk, clearly you want to get below 100. And that represents about the 25th percentile of the population. But what would be the equivalent in terms of non-HDL? Well, it's very easy. If you have an LDL goal, you just add 30 for the non-HDL. That's 130 for non-HDL. That's also about the 25th percentile for the population. Well, how about ApoB? Remember, I keep harping on the fact that it's total atherogenic particles that are causing atherosclerosis, not some static level of LDL cholesterol. Well, if you wanted to use the same paradigm, the 25th percentile for ApoB 100 would be about 92. Okay? Now, how about diet and drugs? Certainly, we do recommend diet. It's good and helpful. Every time you go on a strict dietary regimen, you can reduce your LDL cholesterol by about 7%. Some individuals are not very sensitive, particularly those who have FH. The receptor is just not very functional. Some other individuals who have polygenic hypercholesterolemia or familial combined, they often are very sensitive to diet. And think about the fact that if you lowered your LDL cholesterol by about 7%, that's about the equivalent of doubling a dose of a drug like a statin. So you can use half as much, or it's twice as effective. It can save you a lot of money. So what drugs might we think about doing in terms of lowering LDL cholesterol? So in terms of the schematic here, we have the intestines, the gut on the right, we have the liver in the middle, and we have the extrahepatic organs here on the left. And the LDL receptor is here, where, remember, we're secreting VLDL, and that gets converted to the LDL. Well, it turns out that the LDL receptor expression is directly linked to the amount of cholesterol in the liver. The liver, like all organs, is pretty intelligent, and it has homeostatic feedback mechanisms. So it needs to have a certain amount of cholesterol. And when cholesterol is decreased within the liver undergoes mechanisms to increase the amount of cholesterol. So one way the liver can increase the amount of cholesterol is to capture more LDL particles and bring them into the liver and increase the cholesterol. So anything you do to decrease intrahepatic cholesterol will upregulate the LDL receptor. Well, one way we can do that, you may recall, that bile acids, which are important for absorption of cholesterol and fat from the diet, they actually are products of cholesterol metabolism. Their precursor is cholesterol. And they are secreted into the gut, and then they are reabsorbed via the enterohepatic loop. And if you give bile acid resins, they basically bind up those bile acids, and they're excreted out in the feces, and you're essentially draining cholesterol out of the liver. So the liver would respond by upregulating the LDL receptor. Likewise, there's a absorption receptor for cholesterol, the ABG receptor, that actually absorbs cholesterol from the gut into the liver. And if you inhibit that transporter, basically you're not absorbing as much cholesterol, and you're again depleting intrahepatic cholesterol. Now, of course, the most effective way to decrease intrahepatic cholesterol is to block the synthesis of new cholesterol. And we have inhibitors of the rate-limiting step, which is HMG-CoA reductase. So if you have an HMG-CoA reductase inhibitor, otherwise known as statins, they inhibit that rate-limiting step. You reduce intrahepatic cholesterol, and the liver will respond by upregulating very potently the LDL receptor. Now, other ways we can do this, niacin is not a very popular drug, but it is available. And the way it works is by reducing the secretion of VLDL. So you're reducing the input function on something that will eventually be converted to LDL. So that may modestly also decrease LDL cholesterol. Oh, one other thing. Plant stanols, these are things that are common in some plants. You can also get things like Benecol margarine, and those work like the cholesterol absorption inhibitors. So remember, the liver is secreting VLDL, gets converted to as a remnant, then LDL. That LDL can be taken up by the liver or by LDL receptors in the periphery. The VLDL remnant can also be taken up by the same receptor that takes up the LDL. So anytime you decrease intrahepatic cholesterol, you're going to be sucking up LDL and also VLDL. And if you use a bile acid resin, the liver will respond by upregulating the LDL receptor. But the liver is also intelligent. It says, well, you know, I need more cholesterol. Why don't I increase cholesterol synthesis? So therefore, if you blocked cholesterol synthesis with a statin and you had a bile acid resin, you can have like a 1-2 punch. It's a very synergistic combination. So you can get very potent decreases in LDL cholesterol because you very potently increase the expression of the LDL receptor. Likewise, you could use a cholesterol absorption inhibitor. Okay, let's go back to our gentleman, Paul. He's 50. Remember, he's sort of sedentary. He's been gaining weight. And we said his cholesterol and triglycerides were high. His LDL is high. His HDL is low. His 9-HDL is high. But let's look at the big picture here. Now, back 5 years ago, admittedly, he weighed 5 kilos less. But, you know, here he had, you know, pretty good cholesterol, sort of borderline, if at all, elevated. But triglycerides were high. LDL was really not that remarkably elevated, but now he's got a very significant combined hyperlipidemia, and we notice that he does have a family history of premature coronary disease, and there are 4 kids. He's got a combined hyperlipidemia. His brother's got high cholesterol, so 2 of 4 kids essentially have what appears to be a genetically inherited hyperlipidemia. So any thoughts on what disease this guy has? And there's a really other major hint on this page here that I haven't pointed out yet. Any thoughts? Well, he's got a combined hyperlipidemia. So they're basically, so we agree that probably he's got a genetic dyslipidemia, right? Seems like there's, in the family, there's, you know, yeah. He could have hyper-ApoB. So, but what are the factors here that really imply that he does have hyper-ApoB, that he's got familially combined hyperlipidemia? First of all, he's got a hyperlipidemia that's sort of shifted from hypertriglyceridemia to combined hyperlipidemia. So he's got a hyperlipidemia that's sort of shifting in time. 2 of 4 siblings have something. So it seems like he's got an autosomal dominant something that's inherited. His father had premature coronary disease, so there's increased risk of coronary disease. And he has hyper-ApoB. So he's got familially combined hyperlipidemia. He has hyper-ApoB. So this is clearly what this gentleman has. Now, let's say that he had triglycerides of 250 back 5 years ago, and now his cholesterol is maybe 205, but his triglycerides are 270, and we measured his ApoB, and it was 95, 100. It was about 50th percentile. Well, that would be consistent with familial hypertriglyceridemia. Okay, you sort of understand how I'm making the distinction here? And the reason we're fixated on documenting one versus the other is one is clearly and unequivocally associated with increased risk of coronary disease, and the other one, not really. Okay? So we said total cholesterol is high, triglycerides are high, HDL was low, LDL is high, non-HDL is high, ApoB is high. By the way, does he have small dense LDL? What do you think? Sorry? I can't hear you.
So no, I don't think he does. We just have too many LDL particles, but they should be a regular.
Okay. Whenever you have hypertriglyceridemia, until proven otherwise, you have small dense LDL. And the way you determine whether you have small dense LDL is if you have too many particles. What's synonymous for too many particles? Too many ApoB containing particles, high ApoB. So if we measured ApoB and he had hypertriglyceridemia and his ApoB was normal, he wouldn't have small dense LDL. Okay? Now, most of the time when you have hypertriglyceridemia, you do have small dense LDL. So what defines the fact that he's got too many particles and he's got small dense LDL is the fact that he's got hyper-ApoB. But all things being equal, if anybody has hypertriglyceridemia, just assume that they do have small dense LDL. Yes?
Every ApoB-containing molecule will have the same amount of ApoB, regardless of whether that person has.
Well, there's one copy of ApoB on every LDL, IDL, and VLDL.
Regardless of the size.
Right. What's different is the size of the particle and how much triglyceride and cholesterol is on the particle.
The size of the particle,
Well, when you go back, when there's a lot of particles around, CETP will act on them and will deplete the cholesterol from the particle in exchange for triglycerides, and then that particle will be acted upon by LPL and shrink it in size. Okay? All right. So some other things I sort of pointed out in passing, his glucose and his hemoglobin A1C, which is sort of a marker of long-standing glucose control, is sort of borderline elevated. We also call that impaired glucose tolerance, which you'll get in the diabetes lectures. His blood pressure is sort of borderline elevated, and again, he had a family history. So what are his lipid and metabolic abnormalities? So I told you, high cholesterol, high triglycerides. His LDL is unequivocally elevated, his non-HDL is unequivocally elevated, and most importantly, his ApoB is elevated. He's got small dense LDL. Clearly, he's an increased risk for coronary disease. In addition, he's got borderline diabetes, which is a problem as well, which, if unchecked over time, probably would lead to diabetes. So does he have a genetic dyslipidemia? The answer is unequivocally yes. He's got familial combined hyperlipidemia. Is he at increased risk of coronary disease? The answer is unequivocally yes, he does. What secondary lifestyle or environmental factors might be important here, and what might you target, and what should you do? Sorry?
He's sedentary.
Okay, he's sedentary, so suggestion, implication is we should get him moving. Absolutely. Okay. What else? Right. He's overweight, so we want to put him on a good diet, and that's a bit of a controversy, but certainly whatever diet works for him, a healthy diet combined with exercise to get him to lose weight, that's going to improve his glycemic control, that's going to improve his hyperlipidemia. Absolutely. Definitely. Okay. Good. Good. Now, he's not a smoker, but if he was a smoker and he had low HDL cholesterol, we'd obviously want him to quit just because that, increases his risk. Yes? Right, so he's sort of a borderline hypertensive, and the definition of what is actually hypertension is a little bit in evolution. But suffice it to say that's at least borderline. And if he lost weight and exercised, his blood pressure would probably come down too, as part of the metabolic syndrome. Absolutely. Yep. And you might consider putting him on a low-salt diet. Okay, so what should your goals of therapy be here, other than healthy lifestyle, which we all agree on, I think? So how about in terms of his LDL? Yep. Right, so the guidelines suggest that the optimum for all people in the population is an LDL less than 100, and the guidelines additionally say you want to be very aggressive about doing that if somebody is at high risk, which is defined as anybody with coronary disease, peripheral vascular disease, or type 2 diabetes. Now, we know that this guy has impaired glucose tolerance, so he essentially almost has diabetes. So you could say, well, that's, and that's almost the equivalent of having diabetes. That puts him in the high-risk category. But we haven't even included, in terms of the risk calculation, the fact that he's got small dense LDL, he's got hyper-ApoB. That puts him at increased risk. In addition, he's got a family history of premature coronary disease, and he's got impaired glucose tolerance, which is almost the diabetes equivalent. So this is a guy who's really at high risk. So he's, quote-unquote, primary prevention. The guidelines might suggest, well, just get him below 130. That's okay. But, as endocrinologist, and I'm sure my colleague Dr. Epstein up there would agree, this is somebody we would probably push below 100. Now, we said that diet can get you down about 7% or so. Now, his LDL concentration was 175. If we wanted to get him down to 100, that's a 43% reduction. Would diet be sufficient? No. No. I mean, even to get him below 130, it wouldn't be sufficient. So you're going to need a drug, and a pretty potent drug. So what potent drug would target particularly ApoB 100 containing particles? Anybody? I sort of hear murmuring. Well, niacin prevents the secretion of VLDL, so it's the input function. But what is the most potent class of drugs for lowering ApoB 100, and what's the most common ApoB 100 containing particle? What's the predominant ApoB 100 containing particle? Okay. Remember, in the ApoB 100 cascade, we have VLDL, IDL, LDL. What particle is the most common in circulation? LDL. So I'm basically telling you what drug is most effective in lowering LDL. Statins, right. So we would want to treat this guy with a statin. And, with statins, you can easily get, 40 to 55% LDL cholesterol reduction. So we could put him on, say, 40 of simvastatin or, 20 of atorvastatin, something like that. Bring his LDL from 175 down to 100. We'd combine that with diet and exercise, so he'd be robustly below 100. So we could do that. Now, would it be wrong to use a bile acid resin or ezetimibe? No, it wouldn't be wrong, but in as much as you have to very aggressively reduce his LDL cholesterol, they wouldn't be effective enough. There you're talking about 15, maybe 20% reductions. So statins really can get you, 30, 40, 50, 55% reductions. They're by far the most effective, easy to use class of cholesterol-lowering medicines. Okay, I sort of have gone through everything at this point. We have a few minutes left over. Are there any other questions? Hopefully that was pretty clear to you. I sort of dropped a few hints along the way as to what's important. You should definitely take that to heart. Yes?
Just sort of for the lecture, I've got 10 more pages of slides.
Right. Okay. Oh, thank you very much. That's my next slide here. So there are supplementary slides, and this is for your own edification. So what I went over in terms of my lecture here is what you really ought to be concentrating on, along with the handout, the syllabus. The rest of those slides are supplementary slides in terms of the evolution of treatment paradigms, how we're evolving away from LDL only, the fact that atherosclerosis is an inflammatory disease, and certain biomarkers that are now starting to be used. But that's sort of out of the scope of this lecture, but I provided to you as a resource, and if you're particularly interested, you can sort of read it, and if you have any questions, you can certainly ask me. So you're certainly not responsible for any slides beyond this point. I just provide that to you as an informational resource. And included at the end of all these slides are slides about all the drugs. So, what are the doses? What are the various brands? What are the, what are the indications, the contraindications, sort of the how-tos. So later on, when it comes to, I think your cardiology lectures, you'll be talking about heart disease and lowering cholesterol and that kind of thing. Or, when you're at that next cocktail party and somebody asks about, what drugs, you can, whip this out from your back pocket and consult it. Okay? All right. Any other questions or comments? Boy, this is amazing. I guess everybody's either so focused on their neuro final or you just know it all by heart at this point, huh? Okay, on the first slide is my contact information. If you have any questions or helpful comments or whatever, absolutely give me a buzz. And good luck. All right, thanks very much. And I'll hang around for a few more minutes if anybody wants to come up and ask me some more questions. Okay, thank you very much.